this important topic on Module 1, Basics of Oncology, and then specifically on approach to abdominal mass in children. I don't have any conflict of interest for this session. So the outline of the presentation will be, I will speak about just a general overview of childhood cancer, and then we'll proceed to how to approach a child with an abdominal mass, what are the common clinical presentations, and what we should look into history, physical exam, and before we make up the differential diagnosis. And finally, we'll briefly discuss about the evaluation in the workup of a child with an abdominal mass. So I think the audience would be a mix of attendants like pediatricians, general practitioners, and I have seen also our fellows here. So I will try to make it more of a general presentation. I may not go into the details, but if you have any questions, you can forward them. So the incidence of childhood cancer, as you know, generally the numbers are variable. Overall, close to 300. Some recent reports from global can estimate that for expected across the globe. But it's really hard to estimate, mostly because of different cutoffs, and then the cancer registries, specifically childhood cancer registries, are not widely available in most countries, specifically in low and middle income countries. But close to 16,000 new childhood cancer cases are diagnosed in the US among children less than 19 years of age. This would give us one case of childhood cancer per 5,000 children per year will be diagnosed before they celebrate their 20th birthday. So as an overview, despite this low incidence rate as compared to cancer in adults, pediatric cancer or cancer in children, it remains the leading cause of disease-related mortality, both in high and middle-income countries. But in sub-Saharan Africa, it's vastly underdiagnosed. And that's why we are making this kind of sessions for increasing awareness among frontline medical practitioners to fill the diagnostic gap. So from a study from Bakta, Nikhil Bakta and colleagues, they have estimated that 1 out of 2 cases are missed. So when you make a diagnosis of childhood cancer, you are we think that there are other 2 cases being missed out there, either because of lack of referral or because families may not be able to come. So more than 11 million health years globally are lost from childhood cancer. You can imagine how the burden is from childhood cancer in terms of the life lost from the disease, the disability adjusted life years, and the years that we are losing from early days from childhood cancer, specifically in our regions in sub-Saharan Africa. So it's really challenging to diagnose childhood cancer at its early stage because most of symptoms are they mimic common childhood illness. So it is very important to have a high index of suspicion for early detection and early treatment. When we zoom in into low and middle income countries, 80% the burden, the majority of the childhood cancer occur in these regions. In low and middle income countries, 85% of them, they are from LMICs. And only few of them, 15% of them, are coming from high-income countries, but the cure rate is much higher in those regions, contributing the lowest number of cases. If you see this figure from a global report in green, the discrepancy, for example, in East Africa, I'm not sure if you can see the cursor. In East Africa, the undiagnosed cases are much higher than the numbers which are diagnosed. But if you see in North America, almost the number of undiagnosed cases are non-existent. They're negligible. They're negligible. So epidemiology, just as an overview, majority of childhood cancer globally are from leukemias. The numbers might vary, but specifically in sub-Saharan Africa, in some countries like Uganda, you can see a lot of lymphomas, Burkitt lymphomas. But generally, including in Ethiopia and then specifically in the north of Africa and in Egypt and in Morocco, you can see a lot of leukemias. It has a Western pattern. Brain tumors are second on the list, but for some reasons, brain tumors in majority of the countries in sub-Saharan region, they're not the second most common, rather lymphomas are there. But we have a lot of Wilms tumor, neuroblastoma, and retinoblastoma as well in this region. So our focus for today will be abdominal mass, so we'll be focusing on these solid tumors. If you see the incidence of cancer, it varies between ages. The younger the age, mostly it is leukemia or brain tumor or other embryonal tumors. The older the child, or when we go to the age of adolescence, it's mostly bone tumors, germ cell tumors, and also Hodgkin's lymphoma. So leukemias are quite common in the age group between 1 and 5 years, and then during adolescence, bone and soft tissue tumors will predominate alongside with Hodgkin's. But survival, if you see the survival rate of childhood cancer, again, just like the discrepancy in incidence, there is a huge discrepancy among survival between high and middle income countries. So through the years, because of advancement of supportive care, clinical trials, and other factors, outcome of childhood cancer has significant, there is discrepancy in survival outcome in LMICs. So this graph will summarize what we have been discussing so far in terms of incidence and mortality discrepancy in high income and low income countries. So what are the unique, what's unique in childhood cancer? You all know this, what we are speaking about when you say uniqueness. So we don't have screening tools for childhood cancer. So our low-hanging fruit is just timely diagnosis and appropriate diagnosis. And then it's not preventable. Childhood cancer is not preventable, but we can prevent morbidity and death. If we can detect them early and if we treat them properly, it is highly curable. And multidisciplinary approach, specifically for solid tumors, it's highly important. A shared decision-making and multidisciplinary approach has proven to be effective in improving outcome. And generally, outcome of childhood cancer is good when it is detected early. So we'll go now into the main topic of the day, abdominal mass in children. So childhood cancer could present in so many different ways. And one of the commonest presenting feature for childhood cancer is abdominal mass. So the general truth or the general principle is, until we prove otherwise, it should be considered as malignant in origin. That's why we say it. The main purpose is just to rule out that there is no something serious like cancer. You have to you'll treat it very early. If it's not cancer, that's good. You'll exclude by timely diagnosis. So mostly abdominal masses are detected by family member while they're bathing them or changing clothes, diapers, and then a primary caregiver sometimes can pick them on a general physical examination, or it can be, detected when it is, huge enough to be seen. But it is generally common presenting sign of a malignant solid tumor in children. As a symptom, families could complain abdominal pain. We have patients who presented initially with pain, and that was considered as acute abdomen by primary care physicians, and then upon proper evaluation and imaging, there was a huge mass, retroperitoneal mass. So pain could be the initial presenting feature. The mass could be there growing slowly because the retroperitoneal space is capacious and it may not, be easily detected. until it grows bigger and compressing organs, resulting in pain, vomiting, constipation, or sometimes subacute kind of obstruction. So there are, it doesn't mean that all masses are malignant. There are benign abdominal conditions that could present with an abdominal mass, but until we prove it otherwise, we need to consider them as malignant, and they need a thorough workup. So this workup usually happens in a tertiary care setting where there is a multidisciplinary team. So timely referral is very important, or timely consultation is very important to settle the diagnosis. So the most common abdominal mass in infancy and childhood are not malignant. Just there are a lot of benign conditions, but you have to always think about serious conditions like cancer. So mostly, although it varies depending on the age of the child, mostly abdominal mass in children could be from a larger liver, larger spleen, or it could be feces. The general taught in medical school, the five Fs. It could be one of the Fs is feces, or it could be full bladder. But it could still be pathological and more of a serious condition like abdominal tumors like Wilms tumor, neuroblastoma, or rhabdomyosarcoma or teratomas. We'll see them later on. So the classic mnemonic used in medicine that I have mentioned earlier, the five F's could be fat, fluid, or flatus, or it could be an impacted stool or a fetus in adolescents, in adolescent girls. But the fifth F is not cancer. All cancers are fatal, but just they label it as fatal mass or flipping big mass. So you have to think about this when you approach a child with an abdominal distension or an abdominal mass. Always you need to consider this could be a malignant in origin. So important factor is age. Age is a very important factor to narrow our differential diagnosis and to limit the workup. Age of the child or the infant is very important. Our differentials for a neonatal age presenting with an abdominal mass is totally different from an older child or toddler with the same presentation. Duration is very important, and this could align with the fact that all abdominal masses are not malignant, because there are some inflammatory conditions, there are a lot of acquired conditions that could present as a mass. So the duration is very important. And associated symptoms, what additional symptoms are there together with the abdominal mass that would lead us into a list of differential that will help us to focus on the workup. And the site is very important, and it should be precisely characterized in our physical examination. Organ of origin can be settled if you practically, with your physical skill, with your physical examination skill, if you can locate the site of the mass, you can narrow the organ of origin. But sometimes when the mass is big enough, it may be organ of origin, but at least based on the site, you can suspect the organ of origin. So based on the etiology or the underlying cause, it could be congenital if it happened since birth. Obviously, it could be solid or cystic. Solid masses are always, they're mostly malignant, and it could be in a congenital solid nature. It could be neuroblastoma, it could be teratoma, or it could be renal tumor like mesoblastic nephroma, or clear cell sarcoma could be there. But an cystic congenital mass, mostly it is either duplication cyst or lymphangioma or hydronephrosis or multicystic disease of the kidney. Acquired abdominal masses could have an inflammatory nature or a traumatic. So pseudocysts like hydatidis, abscess, or tubercular mass, or appendiceal abscess or appendiceal mass could be present, could present as a mass on a physical examination, or it could follow from a trauma. If a child fall from a height and if he had a hematoma, it could appear as a mass. And then the pseudocyst or abscess could also be following a trauma. So we have said that age is very important. Age is very important in narrowing the differential diagnosis. You don't need to remember all this list of differentials, but if you have an infant, uh, mostly the mass are located in the flanks. Mostly the mass are located in the flanks, and majority of them are originating from the kidneys. This could be from hydronephrosis or polycystic kidney disease or mesoplastic lymphoma or ectopic kidney or commonly renal vein thrombosis, nephroblastomastosis, or rarely, although Wilms tumor is rare among children or infants less than 6 months, it could be Wilms tumor. So the majority of infantile flank mass are originating from the kidney, but there are non-renal conditions that could present as flank mass in infants. It could be adrenal hemorrhage, neuroblastoma, or teratoma. So generally, as a fact, in infants, majority are originating from the kidneys and they are located in the flanks, and they are mostly benign. It could be intraoperative conditions, and this could be from either duplication cysts or disease related to meconium or mesenteric cyst, or it could be related to hepatobiliary conditions like hepatoblastoma, hepatitis. The rest arise from the pelvic, and then it could be hydrometrocolpus of ovarian cyst or teratomas. In older children and adolescents, again, the flanks are the commonest sites for malignant abdominal tumors, and mostly in more than half of the conditions, they arise from the kidneys. This could be Wilms tumor or cystic diseases, and hydronephrosis could be the cause of a flank located abdominal mass. And non-renal conditions like neuroblastoma, teratoma, and other neoplasms like sarcomas could arise from this site. In 20% of the conditions, it could be intraperitoneal from a GI mass or hepatobiliary or pelvic. So depending on the age, depending on the site, the differentials could vary. So what's very important here is what is the age of the child and where is the mass located, and what are the additional symptoms that we'll discuss later that will help us to narrow the differentials. And most importantly as well, the characteristics of the mass. If you see some of the differentials that we are listing here, they can be easily excluded or included by just doing that very important clinical examination like presence or absence of tenderness, and also whether the mass is arising from an organ. I mean, is it an organ enlargement or is it a mass by itself? That will help us to narrow the differentials. So for any child with a possible cancer, we need to have a good history, good physical examinations. This cannot be replaced by any kind of test that you are going to order. If you have a good history, a proper physical examination, and a very detailed physical examination, you are almost there. And you can direct direct and limit. You can direct at the same time limit the workup. And depending on the possible malignancy, you will do tests, but first you need to have your own clinical impression. That will only come after proper history and proper physical examination. So if you are based in a referring center or if you are practicing at a primary care physician level, you need to refer them early. If you have that suspicion after brief history, after detailed physical examination, and after a little investigation, you can just refer them for better workup and advanced test. So in almost all cases, the final diagnosis will be done after a morphological review of tumor tissue. So this needs a comprehensive approach. So how do we approach or evaluate a child with an intra-abdominal mass? So the first thing is we need to ask additional symptoms. Mostly families will complain about the mass that they witnessed while they are bathing them, changing diapers, or if it is big enough, they might see them as a glance. So we need to ask them the duration and the severity of symptom, or if there are additional symptoms together with the mass. These are very important. And how fast the mass is growing is very important, especially in some conditions like Wilms tumor. The mass might be slowly growing, and when it ruptures or when there are hemorrhages, it might grow very fast. So that would help us to narrow the differential. And some inflammatory conditions like abscess as well could present very rapidly growing mass. And hematomas as well could present with rapidly enlarging mass. So if it is an infant and a young child, we have said that more than half of them, they are originating from the kidneys. So age is very important in this. So we need to ask them about symptoms related to genitourinary, like hematuria. Is very important. This could happen in Wilms tumor. It could sometimes happen in neuroblastoma. But when it happens, it will give us a clue about the nature of the mass. So in girls, especially adolescent girls, ovarian system tumors originating from the ovary are common. So menstrual history and sexual history are very important. Some adnexal masses could also be infectious in pelvic inflammatory disease. So we need to think about that as well. So what do you want to ask in the history? What do you want to know? Age is very important. Again and again, we have said this will help us to narrow the differential diagnosis. And our target for today is a mass, an abdominal mass. So we need to ask the duration. We need to ask them if there's any change in the size, if there are any associated symptoms. Like in Wilms tumor, as you know, it might only be the mass, but in other conditions like neuroblastoma, you can have a variety of symptoms like fever, systemic symptoms like malaise, weight loss, loss of appetite. This could be associated with malignant tumors like neuroblastoma. Or in abdominal Burkitt's lymphoma, you could have obstructive symptoms, you could have symptoms related to tumor lysis. So it's always good to ask for associated symptoms. And trauma should also be asked. Antenatal and birth history is very important. If there is any antenatal sonogram in some polycystic kidney disease or other mesenteric cyst, if there are lymphangiomas, if there are in antenatal imaging, that's very important. Birth history, like prematurity, associated with some forms of tumor. So it's good to ask those histories. And medical history, family history for syndromic conditions like Beckwith, Wiedemann, and Wagar, and other familial syndromes can be asked. And our focus should be mostly on GI, the gastrointestinal and genitourinary symptoms and other systemic symptoms. This will give us, they are not absolute by themselves, but they will help us. We have said earlier, majority of Wilms tumor patients are asymptomatic apart from the abdominal mass, but sometimes they could have systemic manifestations like primary symptoms or weight loss, especially in settings like ours. When patients came very late, they could have significant weight loss, loss of appetite. So they're not, absolute, but this presence or absence of one or the other symptoms will help us to narrow the differential diagnosis. So on a clinical history, we have said this is important. What are the associated symptoms? What is the duration? Is very important. If there are fever, if they have fever, pain, night sweats, weight loss, these are associated with neuroblastoma, sarcoma, and then some Burkitt's lymphoma present with systemic manifestations. So careful physical examination is very important. We'll discuss this in the subsequent slides because abdominal tumors are associated with some additional, both local finding and distant findings are there. So this slide is from Nelson Pediatrics textbooks. It's a well summarized table that will show patient age and what kind of tumor will you expect based on the age of the child and what are the unique clinical signs and what important laboratory findings are associated with specific types of tumors. For example, if you see Wilms tumor, we have said it's a disease of preschoolers, mostly between the age of 2 and 5 years. And usually they present with unilateral flank mass. But if you look into their eyes and if there is an iridia, that's almost equivalent with Wilms tumor if there is associated syndromes like WAGA and presence of hematuria on your urinalysis or on your CBC if there is polycythemia or thrombocytosis or elevated partial thromboplastic APTT. These are additional suggestive features for the diagnosis of Wilms tumor. Neuroblastoma, children with neuroblastoma are a little younger than Wilms patients, but they're mostly sicker and also they have systemic manifestations. When they present, more than 55% of them, they would have systemic manifestations with advanced stage of a disease. This is manifested with fever, weight loss, and also bone pain and generalized sickness. On urine, if you have a highly elevated VMA and HVA, that's equivalent to a pathologically confirmed neuroblastoma. But you can check on their eyes. That's why we have said detailed history and a meticulous physical examination. If you see on their eyes, and if there are raccoon eyes, if there's obsoclonus, myoclonus, or if there are cutaneous nodules with flank mass, that will give you a clinical impression of neuroblastoma. We have one child who presented with, sorry, maybe the picture is later, but we have one child who presented initially with proptosis, and then she was sent actually at the triage, at the central triage, she was sent to an ophthalmology clinic, and then she spent a few days there, but later they referred us, they linked her us to our pediatric oncology unit, but she had a huge flank mass that was an advanced neuroblastoma. So proper history and physical examination is very important in approaching a child with solid tumors of the abdomen. Non-Hodgkin lymphoma could present as intra-abdominal mass. I have said earlier, it could present tiny ileocecal mass in the ileocecal region, could serve as a lead point, and children could present with inception to settle the diagnosis in addition to the primary tissue biopsy. So rhabdomyosarcoma, definitely it could arise anywhere in the body, mostly in the gastrointestinal, genitourinary, also in the head and neck region. But for our discussion, if it arises from genitourinary as a pelvic mass, usually it presents with obstructive symptoms. Likewise, in the GI as well, it could cause compression of symptoms when it arises from the retroperitoneal structures. Teratomas usually present as abdominal pain, in boys as testicular mass, and hepatoblastoma in younger children less than 3 years, usually present with a large firm liver mass, and alpha-fetoprotein elevation is a hallmark. So the workup again is summarized here. Once we have gone through the history, physical examination, you can dictate the investigation based on the clinical impression. If your clinical impression, for example, is Wilms tumor, there's no need to do bone marrow aspirate unless it is highly indicated. There are some exceptions, but the general truth is for Wilms tumor, we don't need bone marrow aspiration, but we need chest X-ray. That's very important. We need CT scan of the primary tumor and chest as well. But MRI may not be relevant. You can do it, but CT scan is preferred, and also you can have like the workup will be totally different if you have a child with neuroblastoma, bone aspirate, and after tissue biopsy, the diagnostic tests and staging tests would vary. So symptoms of generally intra-abdominal tumors could arise from subacute intestinal obstruction, difficulty of passing feces and flatus or bowel habit change, or it could be just chronic pain, abdominal pain. It could be vomiting, jaundice, or urinary tract obstructive symptoms, or it could be cord compression from neuroblastoma. Age, this is coming again and again, but I really like it because it's very important to focus on the history and physical examination, especially in our regions where majority of our patients are seeking help from primary care provider. It's always good to teach them on the importance of history and physical examination. So we have said earlier, if it is a neonate, it's mostly congenital malformation. Older child is always malignant. When we say older, it's just between 1 and 5, but usually that is Wilms or neuroblastoma. But in older, like adolescents, it could be Burkitt's, or it could be sarcomas or teratomas. So on physical examination, it's very important. We need to calm the child. We need to distract them. It's very important, but we need to be meticulous and gentle as well at the same time. We really need to avoid repetitive and vigorous physical examination in a child with intra-abdominal mass, especially if the family complained that they have seen that they have palpated the child had an abdominal mass. We need to be very gentle and avoid repetitive examination, not to, rupture the mass if it's Wilms tumor, some capsular tumors. They might easily rupture with repetitive and vigorous physical examination. So we need a complete physical examination, not only the abdominal examination, but a proper and complete, starting from vital signs. Some tumors could give you a high heart rate or an elevated blood pressure, like in neuroblastoma, Wilms tumor. And some of the tumors might push the diaphragm, and you might notice a change in the breathing pattern. Fever could be there in the presence of an intra-abdominal mass. This could be from infection, or it could be a systemic sign of malignant disease like neuroblastoma. So check for the appearance, the general appearance of the child, like overgrowth syndromes, or you might see other features. So general appearance is very important. And on the head and neck, we have said earlier, these signs of aniridia, raccoon eyes, proptosis, or Horner syndrome from a sympathetic tumors like neuroblastoma, or dysmorphisms. They are very important. So you have to focus on these signs on the head and neck. Chest examination is very important. A change in the respiratory pattern, either could be from diaphragmatic push, or it could be from metastatic involvement of the pulmonary, the lung, parenchyma, and cardiac and lymph node examination as well is very important. So on abdomen, I've said this earlier, do not over-examine the child, but we need to do a detailed abdominal examination starting from inspection, palpation, auscultation, and percussion. All aspects of abdominal examination should be demonstrated, and we need to palpate all 4 quadrants and 9 regions of the abdomen to look for the, the consistency, the size, and the surface and extent and in line of growth. Everything should be documented, demonstrated, and documented on a physical examination. So at the end of our physical examination, we need to characterize the location and extent of a solid, firm, non-mobile, fixed right flank mass of this size longitudinally and this size on its width, and it doesn't cross the midline or cross the midline. Or you need to put as much characteristics as possible so that will help you to narrow the differential diagnosis at last. So it's always good to know which structures are normally palpable and at what age and what is the limit. That will help you to differentiate what's normal from abnormal. So if any mass is palpated on a physical examination, that should be investigated. That needs additional tests, okay? So any palpable mass, whether the child is having additional symptoms or not, if you palpate a mass in a child, that needs a proper evaluation, investigation. So this was the child that I was speaking earlier. So she was sent to the ophthalmology clinic earlier, but later she was linked after a few days. If you could see her closely, she had a hugely protruded left eye, and on the right side there are raccoon changes, and she's totally pale. She's grossly pale, severely pale. She had systemic signs like fever, weight loss. She was truly sick, but the first person in contact didn't examine or didn't take proper history, didn't examine the abdomen, and they really missed the flank mass, and they thought this is a primary eye disease, a primary eye disease. So abdomen should be gently examined. It's coming again and again, but it's really important. So uh, if you see this flank mass, this is a picture from Cure for Kids. So this slide, it shows that a huge erythropoietin mass in a young child, probably he's an infant, before it gets detected, pick it early for the families. And for the other thing, the erythropoietin space is capacious, and it might allow for the mass to grow this big. So history is very important, physical examination is very important. And after this, what are the common intra-abdominal tumors? So we have limited tumors. Majority are non-malignant, we have said, but if it's malignant, this could be lymphoma, or if it's in the right part of and upper part of the abdomen, it could be liver tumors, like if it's young, hepatoblastoma, or if it's older child, it could be hepatocellular carcinoma. Ovarian tumors as a pelvic mass, they could present like that, and sarcomas as well can present in the lower part of the abdomen. So age is very important. So pathological conditions in the abdomen, they have some commonalities. So most common tumors, they happen during infancy and toddler between the age of 1 and 3 years of age. So it's typically large when it's detected. It could be the presenting feature, could be the mass only with limited local symptoms, but the exception is neuroblastoma. We have said neuroblastoma had extensive systemic manifestations. So the differential diagnosis depends on the site. If you see this slide from Pizzo and Poplack's Pediatric Oncology textbook, you can see site is very important in listing the differential diagnosis. Whether it's located in the upper abdomen, mid abdomen, or lower part of the abdomen, it's very variable, your differential diagnosis. So how do we ensure the diagnosis? When you suspect a malignant tumor in children, the immediate aim should be to confirm the diagnosis as fast as possible. So you can have a tentative diagnosis based on the age, symptoms, site, and additional signs and symptoms. You can have a tentative diagnosis, but a confirmation, you need to send them to a center where there is a pediatric oncologist, not only pediatric oncologist, but a multidisciplinary team where the child could receive a comprehensive care. So you can limit your workup, but because most of the things should be repeated in the center where they will receive the treatment. So if you have a preliminary information, that should be enough to initiate referral. Timely diagnosis and referral is very important, because the only way we can improve outcome is by early detection and timely treatment. Because when it is advanced, it's very challenging for cure. So the workup includes lab studies, but you can have CBC, you can start with a complete blood count with differential. You can have renal function test, liver function test, and on urine, simple microscope dipstick. But if it is clinically indicated, you can have urinary markers, vinyl mandelic acid and homovaleric acid, if it is clinically indicated, if you have a case under consideration for neuroblastoma. More advanced or specific tumor markers like alpha-fetoprotein, beta-HCG can be done based on the clinical impression, not routine test, but based on the clinical impression. LDH is very important in selected conditions like Burkitt's, intra-abdominal Burkitt's, and also neuroblastoma. uric acid for the same two conditions. You can have uric acid as well. And most important part of the workup is imaging. So we can start with plain abdominal film in most intra-abdominal conditions. This will give us very limited information, but it's good to start with plain abdominal X-ray. You can have like not in majority of the case, but in few cases of neuroblastoma, for example, you can see the calcifications can be seen on plain X-ray. But this needs to be, confirmed with better imaging like ultrasound and also CT scan. But you can start with plain imaging, chest X-ray, and abdominal ultrasound, very important, widely available, but highly informative. Again, at least it will tell the organ of origin, extent, and the nature, whether it's solid or cystic. And then you will have a definitive or more accurate cross-sectional imaging CT scan and MRI. So on this plain X-ray, you can see a paucity of ball gas and huge like opacity in the ball gas are, pushed to be a huge intra-abdominal tumor of any nature, but at least it will tell us there is a big intra-abdominal mass pushing the ball gas laterally. But if you do more advanced tests like ultrasound, a CT scan, you can have a better picture, Like the same patient, when it goes into CT scan, you can have a close sign. The red dots, the outline, a huge renal mass, and mostly solid. And then the yellow arrow, it indicates a remnant of a normal renal parenchyma forming a close sign. And at this age, this is mostly Wilms tumor. Another CT scan image showing a huge renal mass, solid, mostly solid, no calcifications visible, but apparently there are normal renal parenchyma forming again another close sign. This speaks for Wilms tumor. So when should we refer? If you are located in a referring center, any child with a flank mass could be renal or non-renal, but any child with a mass should be referred as fast as possible, as early as possible for better diagnosis and treatment. The child could come for another, it could be child visit for another clinical symptom, but it's always good to palpate their abdomen. And if they have asymptomatic, even if they have asymptomatic finding, intra-abdominal mass, they need to be referred. Any flank mass, any child with a mass plus hematuria plus hypertension, they should be referred as well. Because if they have these features, they are mostly malignant, but they are highly curable when they are detected early, unlike malignancies in adults. So this will be the end of my presentation. Thank you for your attendance, and I'm glad to accept questions.
Thank you so much,
Hello, can you hear
Professor.
me?
Yeah. Thank you so much, Professor, for your clear, well-structured presentation. Very excellent. Thank you very much. We will open the floor for questions. Please raise your hand or type it in the chat box. There is a question in the chat box. If I have suprarenal mass with peripheral plus, how should I approach? Professor, can you hear this question?
Sorry, you are breaking. I can't hear you well.
There is a question in the chat box. Someone is asking if
Sorry, I'm reading.
you read it. Yeah, sure. Go ahead, please. Would you like me to read it again?
Sorry, my internet
Can you
was
hear me
breaking
well?
at last, but yes, sorry. I read the question on the chat
Oh, it's
box and I'll try to
okay.
reflect on that. Yeah, so the question, if I clearly understood the question, is suprarenal mass with abnormal peripheral blood count, or?
I think it's plus, prefer plus. Please clarify the one who's
So,
asking the question if
yeah,
you would like to
so
clarify
basically,
it.
suprarenal mass with abnormal blood count is all blood. Oh, interesting. Peripheral blast.
Yes, prefer plus.
Interesting. Mass, it could be, I would suspect in this situation, Burkitt's lymphoma. Burkitt's lymphoma leukemia could present with infiltrations, mostly renal infiltrations that might mimic suprarenal mass, and then abnormal blasts on the peripheral Burkitt's, but still some leukemias can infiltrate the kidney and they might present. Mostly, it is not clinically detectable on imaging.
Okay. Are you here?
Yeah. The internet is really poor.
You're
Yeah. If there are additional clinical symptoms and signs, I really want to get more information about the question, but if there are peripheral blasts and mass, suprarenal mass on imaging, mostly in imaging, that is usually in Burkitt's, and also that could happen in some forms of leukemia. That was what I was referring.
Professor, are you still with us? Please, everyone, can you hear me? Do you hear me?
Yes, we can hear you. Probably it is Dr. Mulugeta's internet that's interrupting.
Yes, it's having a problem. Professor
Yeah.
Mulugeta, thank you. Can you write down in the chat box if you are with us?
Or if not, the questions can be emailed to him.
Yes, sure. If he approves, I can share his email so he can send the questions. I'm so sorry. I think Dr. Mulugeta is having a technical problem. We can wait just for a couple of minutes. He might be able to restore the connection. Thank you.
I have internet issues, but I'm back now and willing to accept questions.
Yes, we can hear you now, Professor.
Yes, there was internet break, sorry. I hope you have heard my presentation. I'm really sorry. The internet is really breaking now and then.
It's okay. We can follow you and the connection is good.
Okay, thank you.
Okay, that's it. Was the question answered properly for you? Or do you need to repeat? I think there is no further questions. Thank you very much, Professor. It was a very excellent presentation, really to the spot. Thank you, and we hope we could have you again in the following lectures too. Thank you for your time.
Thank you, John. Thank you, everyone. Thank you, the organizers, and have a good time.
Thank you. Bye.